So we're going to talk about the carotid today in ophthalmology. And as you know, the common carotid artery supplies both the internal carotid artery and the external carotid artery. The common carotid artery is coming off the aortic arch, and on the right side we have brachiocephalic coming off the arch, and then the common carotid on the left and the subclavian on the left. But today we're going to concentrate on the internal carotid artery. So once the common carotid comes up, it bifurcates into the external carotid artery, which supplies the external parts of the face and head. The internal carotid artery goes up into the head, has a petrous segment that is going to be horizontal and then vertical, and then goes up into the head and has an intercavernous internal carotid artery, and then above that is the ophthalmic artery, and that's the supraclinoid portion. So we've got a cervical portion after the carotid takes off from the common carotid. We've got the petrous portion, the cavernous portion, and the supraclinoid portion of the internal carotid artery. So the way this comes to us is you can have a common carotid occlusive disease, which will affect both the ICA and the ECA. You can have a more common cervical carotid disease, and so that's going to present to us as amaurosis fugax, transient monocular vision loss. And because the sympathetic plexus is running on the internal carotid artery, that can be a Horner syndrome. And so when we have the combination of a Horner syndrome and an ipsilateral amaurosis fugax, you should be thinking about cervical internal carotid artery disease with thromboembolic disease producing transient vision loss in the ipsilateral eye. In the petrous portion, however, we also have to deal with the things that are in the petrous bone. And one of the things that's very close to the petrous portion is the chorda tympani. And this chorda tympani provides the seventh nerve's innervation for special sensation to the anterior 2/3 of the tongue via the lingual nerve. So that produces a very specific symptom called dysgeusia, which is bad taste. So they often describe a bitter or bad taste in their mouth. And so the combination of dysgeusia, Horner syndrome, and transient vision loss is internal carotid artery as well. And any of these, actually, if you have dysgeusia and transient vision loss, that's also a carotid dissection. It can also be a pseudoaneurysm from the dissection causing a false lumen. The intercavernous carotid artery is where carotid cavernous fistula occurs. Normally when you have a CC fistula, we divide it into different letters. In the A type, it's a direct fistula where there's a tear directly in the internal carotid artery, and that leads to a high flow fistula from the ICA. And then the others are low flow fistulas, either from the external carotid artery, the internal carotid artery, or both internal and external carotid. And those define the CC fistulas by the Barrow classification. And then we've got the supraclinoid internal carotid artery. And in that location, aneurysms at the bifurcation of the carotid or at the ophthalmic can produce compressive effects on the optic nerve, or can cause loss of vision because those aneurysms are very close to the optic nerve. And aneurysms in the carotid, in the intracavernous portion, can produce giant intracavernous aneurysms. At the bifurcation point with the posterior communicating artery and the ICA, that's the ICA PCOM junction, that is the location for the third nerve palsy related aneurysm, usually a pupil involved third nerve palsy. And so when you're dealing with the carotid, you really need to know which segment we're dealing with. Is it a common carotid occlusion? Is it a cervical internal carotid artery occlusion? Is it a petrous portion occlusion or dissection? Is it an intracavernous aneurysm or fistula? Is it a supraclinoid aneurysm of the ophthalmic, the supraclinoid aneurysm, or at the junction of the ICA PCOM, the third nerve palsy aneurysm? If you just knew those things, that's pretty much what we need to know about the ipsilateral carotid. One last thing I want to tell you about, which is the ECA is what GCA does. So because giant cell arteritis is a medium to large vessel vasculitis, any pain in the distribution of the ECA, scalp pain, eye pain, face pain, ear pain, neck pain, any of that external carotid artery distribution pain in combination with an ICA problem, ophthalmic artery occlusion, central retinal artery occlusion, or anterior ischemic optic neuropathy or posterior ischemic optic neuropathy, that combination of headache, scalp tenderness, jaw claudication, external carotid artery distribution pain, and ipsilateral or contralateral ICA distribution vision loss is also a sign of vasculitis, and in the elderly person, that's GCA. So you need to know a little bit about the ECA for GCA.